Well, hello guys. Thank you so much for joining us today on the newest edition of the UMiami Neurosurgery Resident Hour. My name is Sumed Shah. I'm one of the PGY ones, and I'll let Victor introduce himself.
And Victor, another PGY1.
So when we were kind of thinking about all these kind of talks to give in the beginning of the year, we thought, when we were students, when we were kind of just starting even to sub-eyes, what were some important things that we thought would be useful when we were in this process as medical students, and actually even as even as interns, things to do in neurosurgery. And specifically the OR itself is one of the most sacred places within neurosurgery, and understanding how that dynamic works and how to be active yet respectful, to be engaged yet distant enough that you're not changing the workflow. It's a very important thing to do, and it's a skill almost to have. So that's kind of the reason why we want to have this talk. And of course, this is always going to be generally informal kind of session. We're going to be sharing information a lot of you probably know. This talk is mainly geared towards MS1s, MS2s, particularly as MS2s are going into their clinical rotations. You guys are going to be in the OR for OB-GYN, for general surgery, and when you do electives like neurosurgery, you're going to be in the OR. So kind of having an understanding of what to do, how to do things, and what not to do in particular is going to be pretty important. Before we begin, Victor, you have any opening statements as well you want to make?
No, but you're right. A lot of judgments get made in the OR, so having a wits about you is always a good idea.
So again, if there's any questions you have, you can use this Q&A bar. You can just stop any of us. This is the time for you guys to ask any of the questions you want to ask, particularly because a lot of these questions, none of us are going to be able to determine who's really asking unless you want us to. This is the time. You don't want to make any fatal errors in the OR or anything like that. Maybe not the best word to use in a medical setting, but you don't want to make any mistakes that you could have prepared for earlier. So to begin the talk, I'm a pretty big, let's see, there we go. I'm a pretty big John Wooden, I'm a basketball player, and John Wooden was one of the UCLA basketball coaches back in the day. And so his quote was always, failing to prepare is preparing to fail. And the OR is no different from that. There are steps that you can take to understand kind of what your role is in that situation, how to be engaged, and really what to do when you're placed in situations to possibly even scrub in, what the different tools even just look like. And I was going through this process, I didn't know the difference between a Rainclip and a this clip and a fish hook and whatever that hook. Like, these are all things that when you're in the OR, you have to know to the next steps and such as an intern and beyond. So at least getting the sense of those words from the get-go will be important. So this is all about preparing, and preparation starts from the get-go. So the general objective that we want to convey to you guys is, one, we wanted to give medical students and interested observers a brief background into proper OR etiquette and equipment specifically encountered in and for neurosurgery. And we also want to offer a forum for you guys to ask any questions you have about OR shadowing. And again, special attention paid to neurosurgery, as this is a neurosurgery talk, but a lot of these lessons of sorts, the general tidbits really work for really any OR setting. So the outline, we're going to discuss basically getting started, the general layout of what the OR is going to look like, down to even like where you would stand, OR etiquette generally, getting into the action, scrubbing in, gowning, the different protective equipment, something as simple as sizing your gloves. I didn't know how to size my own glove. I kind of just tried different gloves until one of them fit or didn't hurt my hand after a few hours. But there is actually at least a starting point you guys can use to determine what glove size you are. Neurosurgery specific tools and equipment, just so you kind of have a sense of what they look like. And then finally, general pearls, and then any questions you have for me and Victor. So getting started. First thing, finding the cases. So when you're going to be scrubbing and when you're going to be joining the neurosurgery residents and attendings in the OR, it's best to understand which ORs we actually use and what the cases are. You don't want to walk into a room and have no idea what's going on. The setups are very different, whether or not we use a microscope, whether or not we use an endoscope for XYZ cases. These are all kind of things you can glean from just simply knowing what the case is from the get-go. A craniotomy at University of Miami Hospital may be a little bit different than a craniotomy done at Jackson. Spine cases, same thing. And so talking to your fellow students, the NSIG group is a great resource for students. Talking to residents like me, Victor, and beyond, and even talking to some of the attendings that you have good relationships with can at least give you a sense of what's going on that week and which room or two you can be in. At University of Miami Hospital, generally we stay in the ambulatory ORs on the first floor. At Jackson, we're in the third floor, and we have like specific rooms, 25, 26, 27, 28, and 29. These are all kind of things that just kind of talking to one of us will help you prepare for which exactly room you want to be in, which case you want to see. And of course, if you can choose the cases with the intraoperative microscopes, those are generally a little bit easier to shadow on because the camera will allow you to see the field of view nicely, as opposed to kind of being very far away in the corner on a spine case that the incisions may be this, maybe like that big. You may not be able to get a bunch of good exposure into the surgical field. Preparing for the case. So for example, if you have if you're going to shadow craniotomy, let's say a craniotomy for a frontal lobe tumor, reading ahead of time, knowing that kind of the general steps of that case help you in the sense that you kind of understand what's going on in the time-wise fashion. When opening, when closing, all these things, this is where you develop a good sense of what to do when, such that when you are scrubbed in as a sub-I, as an intern, you have a sense of what the next step is. When I was on general surgery, one of the attendings always talked, anticipate the next move. And neurosurgery is no different. In fact, probably more important, just because you definitely don't want to change the workflow of the environment if you're in the OR. Greenberg, Neurosurgery Atlas, residents like me, Victor, and beyond, we can help you. There are resources to help you to figure out exactly the steps themselves. And something as simple as arrive on time. You don't want to be late to an OR. You don't want to come in, knowing that, hey, I'm going to shadow Dr. So-and-so in the OR, and then come in halfway through the case. You won't get to see much. You won't get to do anything. And in fact, it'll look like you didn't care enough to show up on time. Introduce yourselves to the residents, the attendings, and very importantly, the OR staff, because they can, in fact, make your life pretty miserable in the sense that they can tell you where to stand. If you're standing too far away from anything, you're not gonna have a good experience. So these are some of the resources that exist. Brain and Spine Group. These are all like you just look them up online. Brain and Spine Group is a new forum for medical students and even young residents entering into the field of neurosurgery. You have textbooks, Neurosurgery Fundamentals, written by one of the PGY7s, one of the chiefs at University of Pittsburgh. Great pocket resource. It's much smaller than this Handbook of Neurosurgery, which is also a good resource, but definitely the information is much more dense there. And then the holy grail, the Neurosurgical Atlas itself, all you have to do is create a subscribe, make a free login, and you can basically go through the steps of any of the procedures outlined in that. So Victor, you want to take me to the general outlay?
Oh yeah, sure. So I just wanted to clarify, Sumed's not getting any royalties for any of those books and stuff that he was just advertising, I'm sure. So yeah, the general, the OR layout. Now, for anyone that's never been in there, it takes some getting used to figure out where to stand. I think when you start, and even now, the question is always, where do you stand? Where do you stand? The basic layout is you'll have an attending there who will be in the most comfortable position ever. The scrub tech will also be in the contralateral or the opposite comfortable position ever, because they're very important. I guess then becomes the senior resident, the junior resident, and then you, if you're an observer or an intern like me, and then you just kind of make do and work your way up the chain. But effectively, I think this image here is set up more for, say, for example, a spine case, which could be the case. Cranial, I guess everyone's kind of moved up more towards the head, but in terms of the setup, you normally stay on both sides, and there can be up to 2 people I've seen at once. So when you watch, just have your wits about you. You can see everyone's scrubbed in. There's a sterile field in blue, and that's where you remain. Can we go next slide, Sumit? And as Sumit said, there's an etiquette, especially when you've just arrived. More likely than not, as is the case when I subbed, and now even the case here in Miami, you're new. Everyone else in the room probably isn't. So you're the new person, and it's about being respectful, I think there's a time to joke and be relaxed, but it's only once you know what everyone's like. So at the beginning, when you don't, always be respectful, like in any sort of group, and that point of asking appropriate questions at the appropriate time, I think, is a very important one, because especially those that are entering their sub-Is or trying to make impressions with people for whatever reason, you want to show that you're engaged, but you also don't want to be annoying. So I think, and this I don't think is specific to neurosurgery at all, but in general is, or just trying to pick your moments. And if there's ever a moment where you're like, should I say something or should I not? I'd probably err towards not saying it if that's the case. Maintaining sterility is very important. There'd be nothing worse than contaminating a sterile field and then being known as the observer, student, intern, resident that contaminated the sterile field. I'm yet to see a sterile field be contaminated, but I dread the day if that ever is me. Um, and by all means, sometimes I think if you want to be involved by scrubbing in, I think you should always, there's always a spare set of gowns, a spare set of gloves that you can get. And the one thing I've started to realize is never be afraid to say you don't know something. Something from, as much as what's that instrument called when if you're trying to get it, or what's your glove size? I don't know what my glove size is. Can you help me figure it out? Just never being afraid to ask something for your betterment within the OR is never a bad thing to do. And so always ask, but always be honest as well. Don't say something that you're not sure on, because in the OR, also on the floors, on the wards as well, always be honest. I think it's a great point to make.
Yeah, I think a lot of the times, and Victor, correct me if you've had this experience, you'll be placed in situations where you may be a little bit uncomfortable. In those situations, maybe something as, hey, help me with this part of the procedure, help me move the patient, help me do this. And by all means, if you know how to do those things, that's the time to really show your stuff. But there's also this, you should also have this academic honesty about yourself, in the sense that if you don't know how to do something, it's okay to say no. If you contaminate something, it's okay to say that. What's not okay is if you, for example, touch a light handle by mistake, trying to adjust the light for one of the attendings or one of the residents, but forget that the light handle has a sterile part to it. And if you touch that and don't say anything, someone will have seen you. There are too many eyes in the OR such that someone will have seen that. But in the very unlikely chance that someone doesn't see that, and one of us or the attending touches that handle, right then and there, that's a huge patient safety issue. So the honesty part is all about the patient safety. We want you to learn, we want to learn, but we don't want to learn at the detriment of a patient's safety. And so that's where that honesty comes really important to play. Blue, sterile. Do not touch unless you're sterile. Simple as that. So the gowns itself, blue. The drapes we use, blue. This IOBAN, this yellow protective film, surrounded by blue, don't touch it. In terms of the actual scope itself, for example, a lot of the cases will have microscopes. That transparent film is also sterile. So generally, you want to avoid, and you want to be very cognizant of where these things are in the OR. Because a lot of the times, things will be moving very quickly around you. You'll be trying to get out of the way or move to somewhere else, and then boom, your head will hit the handlebar that's already sterile. Not a big deal. All we would have to do is be aware of these things, be aware that the microscope drape is now contaminated, so we can fix it. Or, having that awareness, that proprioceptive awareness of where the microscope is, where the Mayfield is, the Mayo stand is, where that back table where the surgical equipments are. These are all important. They're delineated with that blue, the blue drape for a reason, so you can see it very clearly. But having an understanding where these things are and where you can stand, that takes some kind of finessing, some getting used to, and that's why people like me, Victor, Damien, other medical students, that's why we're here, is really to help facilitate that. Because when you are a sub-I and when you're an intern, these are things that you cannot make mistakes on as frequently, or else people will start to notice. And the worst thing, the thing you don't want to have said about you is that, he or she's a great student, great applicant, but has no sense of the OR. Neurosurgery, the surgery part has more letters than the neuro part. So you're going to be a surgeon. So you have to have a good OR sense.
And that sense develops over time as well. It's not like something. I think the hardest thing, and I still put this on myself, is I walk into a room and I'm like, well, I expect to be able to do everything. When ultimately, I mean, you're not expected to know how to do all these procedures from day one internship. And indeed, as a student, I've been in this job for 8 months or so with Sumed, and if anyone was to come in, I know what I knew back then, and I wouldn't expect anyone. I would not be surprised if someone didn't know a lot of this stuff, this awareness stuff, because ultimately it comes from times in the OR, and when you're a student, like, yeah, there's only so much you're in the OR. So I mean, it's a great point, and it's always something you're going to learn. But it's okay to like walk in and be like, man, I'm still figuring out this, because that's how I felt.
Definitely. I mean, the very first time I shadowed in the OR, I was scrubbed in. I had glasses at the time. I got LASIK, but my glasses are about to fall off my face, and my hands reflexively just touched my face to push my glasses back. One of the nurses saw. I mean, not to say like I had any conscious understanding of like it's just a natural reflex. Your glass about to fall. You don't want that to fall into someone's brain, so you put you fix them. That right there, the first time I ever like contaminated myself was the very first time that I like jumped into the OR setting. But these are learning experiences, and on top of that, now I got LASIK, so it's fine. But not to say you need LASIK, but you need to have a good understanding, I think, of that you are going to make mistakes, and part of the reason why you're a medical student, why we're just interns still, is that this is a long road, and you continue to learn, but you need to get into the OR, and you need to have a foundation. And this talk is a foundation. It's not supposed to teach you everything you need to know. It's supposed to give you the confidence that when you go into the OR, you have a base building block set to build on. So getting into the action. This is the part that is both simultaneously the most fun part, but also sometimes some of the most, the source of consternation. A lot of the times in medical school, your education on how to properly scrub in comes from Lawrence Sands, who's the general surgery clerkship coordinator at who teaches you how to do it using, like via video, the first day of orientation. A lot of students are going to basically learn how to scrub in that way. A lot of students are going to learn how to do it beforehand. They're going to watch YouTube videos. They're going to watch other residents. They're themselves going to get involved from the early on and just shadow. So this is again to help show you the different types of scrubs that are there. You have wet preps and you have dry. The wet prep is going to be the generic, Grey's Anatomy, scrubbing your hands down, rinsing it with the water, drying your hands, and gowning up. The dry ones are going to be these alcohol solutions that you can put your hand under, and they'll pump out liquid that you use to scrub yourself, or this Avogard gel. The Avogard gel we use more so at University of Miami Hospital, but the Sterile rub is what we use at Jackson. And of course, the scrub sponges are there at both. But the general principle of this is contact time. The scrubbing, that's very important. But for example, if you use a wet prep, you want to have the contact time be sufficient enough to actually kill any of the microorganisms that are on your arms and your hands and on your nails and such. So 5 minutes is generally the time frame that they say for something like a wet prep. Simple. You basically would make your hands wet. You would lather up that sponge, and you would scrub down each surface of your hand, starting with the fingernails. So those really tough bristles is where you would start with the fingernails. 10 strokes for everything you do. 10, 10, 10. 10 strokes. Each finger, the way you should look at it is like a box. The front, back, and sides, you want to scrub each of those 10 times. And do that for each finger. Switch hands. Front of the palm, back of the hand, switch, and then forearm. And then that's your scrub. When you wash your hands, this is a very important thing as well. You want the water to flow down. You don't want water to go from elbow back up, because this is technically unsterile, more so in comparison to your fingertips. Water should come down your hand, and that way you can maintain that level of sterility. And your way you dry your hands is similar. You start from the top and you work your way down, okay? The Sterile rubs itself, you're gonna have a little amount that you place in your palm. It's gonna shoot it out. It's all kind of automatic. So as long as you get a good amount in your fingers, and you're basically going to rub that under your fingernails, rub that into your cuticles and your hands, dry it off. Do the same thing for the other hand, dry it off, and then a third pump to get the hands one last time down to the elbows. The same thing with the Avogard. These are just different ways of doing it. The benefit of using these two systems, the Sterilium rub and the Avogard, is that you don't have to use a wet prep. So you don't have to dry your hands because it dries itself. Victor, anything that I missed on those?
Nope.
Nope. And of course, if you have questions, this is the time. I don't have videos for this because part of this is not supposed to, it's not supposed to be a teach you how to do it. It's supposed to give you the sense of these are the things that exist out there. And when you're interested in learning how to shadow, this is where you would come to talk to one of us and we would do it together. Because this is a very important concept. You do not want to be unsterile as you scrub in. You don't want to ruin your sterility from the get-go. And you want to develop good habits. This is just to give you the word by mouth and what they actually just look like when you see them in the OR places. Getting into the action, gowning and gloving. Victor, do you want to take over this one?
Gowning and gloving. Well, yeah, that's definitely the two key components of getting involved. You scrub, like Suman had described, and then the next stage is to gown and glove. It's to maintain sterility. And as it implies, you have a gown. Some people have these fabric gowns. Some people have these cloth gowns, and these disposable gowns that we have on the left. And then you glove. One thing I'll say. I find very interesting in the US is that when you glove, one of the scrub techs will actually hold out the gloves for you. I can say I'm from Australia, and that doesn't always happen like that. So it's everyone has the different styles, and yeah, you gown, you glove, and again these things like scrubbing in, putting on gowns, putting on gloves, asking what glove size you are or gown size. Never be afraid if you don't know to ask, because everything else is kind of self-explanatory at this point. Next slide, sir.
So in this slide, I wanted to basically show what the consideration of sterile part of your body is. So you are fully, the gown is sterile, but there are parts that are more sterile than others and some that you consider absolutely unsterile at all. The back, entirely unsterile or considered as such. Kind of think of like a strike zone, like a baseball strike zone. Below the waist, a few inches below the neckline, that's the general zone at which you're sterile in the front. Your arms and sleeves are considered sterile, but the axillary regions are not. So a lot of the times I've seen, a lot of the times people will just kind of put their arms in their armpits like this. Technically, it's theoretically fine because it's all sterile, but just so you know, this right here, this motion, some people, if they're real purists about it, may consider that to be unsterile. Putting your arms on your hip like this, dropping your hands to like below your waist. These are all things that can be considered unsterile, and someone can ask you to either scrub out and scrub back in, or can ask you to completely unscrub because there's now, there's a lot of these things where you have an opportunity, everyone trusts you from the beginning, but if you show that, you don't have a good sense of what is considered sterile and what is not, you may be asked to change and either unscrub and stay like that for the case or have a chance to re-scrub again. For them, it's a really operator dependent. Either way, don't take offense to any of that. It is purely for patient safety, and it's also a learning experience for you. When you walk around the OR, kind of having your arms like this, or like at least kind of cradle them like that, that's fine. But your arms should basically be not above that neckline, but not below your waist. So that's why, people walk into the OR with their arms in like a 90 to 45 degree angle range, because they want to make sure that their hands are in front of them so they know exactly that they are always sterile. And this is just a quick little rundown of the sizes. So the sizing of the gloves from 5.5, 5.5, all the way to 9 is really kind of dependent. It's a person-to-person thing. A good way to gauge where you are is what glove size do you use for just regular exam gloves? I'm a large, and so 8 under glove and 8 over glove are what works for me. Some people are 6'6", 6.5", 6. You don't have to have the same number for the inner glove and the outer glove, That's something, as you continue to scrub in and learn which gloves are most comfortable for you, that's how you'll know. I started off as a 7 and 7.5, and the 7 was too tight on my hand. It basically compresses that hand because I didn't know how to gauge myself in terms of like the glove size. And your hands start to hurt after a few hours of being in that glove because they're just going to compress the muscles in such a way where it's not pleasant. Generally, the inner glove is always a different color than the outer glove. Blue, green, brown, depending on the material and the strength. But that way, if your outer glove ever rips, you have a good sense of where it ripped because you'll see the color much more clearly. Or if there's liquid that gets underneath your outer glove, you'll be able to see it because the blue or green or whatever inner glove will basically adhere very closely to the outer glove because of that liquid layer in between. You'll know that your glove ripped. You know that you have to change your outer glove. And generally the outer glove is the standard white glove.
Always have a scrub cap. Yeah, you actually won't be allowed into the operating room without one, so that's not going to stop you from getting into an OR because you won't be in the operating room area without one. Mask is good. I feel like in the days of COVID, even something that you even normalize even more now. Eye protection's a big thing. Obviously, if you have loops, you could wear those as eye protection. If you have spectacles, you can wear those. But generally, if you don't have either, there have been cases where I haven't had eyewear on, and then you're drilling bone and you realize you need them. So sometimes they're very lovely, and they can get you this lovely disposable eye protection that you see here on the right. But always, I think it's a little bit different. I'm not impressing anyone as an intern. Not having eyewear on, but I think it's a little bit different if you're a sub-eye, for example, and not having eyewear on. So always keep your wits about you. And even if you don't think you need them in the case, even if you're like, hey, there's not going to be much, bone chips or much fluids or anything, there's never any issue with wearing them. In fact, you look more prepared, which is always something people like to see, and something I'm trying to take on myself as well. So always try to, when you're getting into the action, always have these equipments ready. Needle stick injuries, and these are important. And the thing is, accidents happen, and to sort of summarize what we're saying is you have to look after yourself and you have to look after the patient. If something goes wrong, you have to keep everyone's best interest in mind and say what's happened. Don't take on responsibilities that you don't know what's going to happen, and put yourself or the patient at risk. For example, closing. If you don't know how to close, you should not try to close because it really puts the patient's healing process and the wound at risk for infection. And at the same time, if you feel faint or lightheaded, it's better to sit down rather than sort of like try to battle away and then maybe risk contaminating the patient, hurting yourself and hurting the patient. So like always being aware and keeping your wits about you, I think is very important. Specifically, an example is needle stick injuries. Now this is super important. People say anecdotally during your training it will happen to you at least once or twice. Even you trying to be very careful yourself. And they're very important to recognize, very important to acknowledge, and very important not to underestimate. Now, the biggest concerns obviously bloodborne diseases that may be unknown and then contaminated and maybe spread. So never ever take anything lightly. Better be safe than sorry. These things, often these serious things, require documentation. And there are a number of, depending on what institution, right, there are a number of protocols in place, a number of management lines. This can include a hotline, going to the emergency department, registering for something else. So always acknowledge it, never be afraid to say it, because it's better to be safe than sorry, and you've got to look after yourself as well.
And again, if you have any questions about this kind of stuff, if you have no idea how to close and want to learn how to close, we have no issue teaching these kind of things. But the reason I specifically brought, the reason that when we were discussing this talk, why we wanted to bring that one in particular, the taking on responsibilities before you can, is because it also puts the resident at risk too if you don't have a good sense of how the needle driver works. You don't know how the tissue tensile strength will changes how the needle goes in. You don't know how the needle itself, the different ones cut through the skin. You can really, and I mean, I've gone through since like, situations where I'm trying to pull the needle through and then it gives very quickly. And so then I like the needle, I don't say fly somewhere, but the needle is like not as controlled for that. Like just even the 2 inches, that it's not like it's not controlled. These are where the needle stick injuries happen. And I've seen fellows get needle stick injuries closing with attendings. I've seen, like intern level residents get hurt while closing. These are not things that they happen to everyone at every level. But this is important to kind of understand. If you're going to go into the OR, you do open yourself up to these situations you need to know how to handle. I knew someone who fainted in the OR. He vasovagal, fainted, had to be taken out of the OR by a stretcher. Like that's not something, that was when I was a first year. Like those are not kind of things you want. I know I'm like 5 years away from that and I'll never forget kind of like that. So it wasn't me, by the way, Victor, if you're wondering.
I wasn't thinking that.
Onto neurosurgery specific equipment. We're kind of coming to the conclusion of the generalized talk of what this is. Again, it's supposed to be more of a baseline to give you the tools, give you the generalized confidence to be successful when you go into the OR, but more so to allow you guys to know that there's a lot of things you need to learn. A lot of things that Victor and I are still learning at this process. It's just a continuing learning process. But this way, at least when you go into the OR, you have a good sense of, oh, that was, I introduced myself to the circulator. Oh, and now I kind of, I like get out of the way because things are moving too quickly. There's a potentially emergency situation happening. I should step back. Something as simple as what your interpupillary distance is. I didn't know what that was before I started the residency, but every one of these microscopes, which is one of the neurosurgery specific instruments, a surgical microscope, you basically have to change how far the eyepieces are from, such that you can actually see properly one field of view versus 2 separate fields of view for each actual magnifying lens. Something as simple as that, like you're never gonna know that you have a very unique interpupillary distance. I know mine's 65. Like, fun fact, I didn't know that until I started scrubbing into the ORs as a sub-eye. So these are something.
A good number to start off as well.
Yeah.
When you don't know.
Yeah, exactly. And also there is a part of the eyepieces that is an unsterile part. So if you touch that, you're considered unsterile. So having a good sense of what you can and cannot touch, it really just need to go into the OR. But operating microscope, one of the things that you'll be able to use to see the actual surgical field if you're not directly scrubbed in. If you are scrubbed in and the tending and resident are under the scope, stay sterile. There's still an opportunity for you after the microscope gets removed from the field that you're going to help close, or you're going to help with still kind of retraction, putting the bone flap back on if it's a cranial case. And again, if you're given the opportunity to look through the scope, just use that time to figure out exactly what your distance is, because it also kind of indicates to other residents around that, oh, this student has been in the OR. They know that they have to change the scope to their interpupillary distance. And remember that plastic drape is sterile. So sometimes, if your head hits that drape, that part is considered unsterile. So the next one is a stealth navigation system. These are all these kind of like tools you'll see in the OR that you may not have you may not know what they do or how to manipulate them if one of the residents asks for help. Essentially, this is how it's like our GPS system in the surgery OR. This piece right here, this kind of winged arm, has these 2 black sensors that will pick up the brain and the relationship of different skeletal landmarks on the skull landmarks and the actual skull itself in relation to the distance from this star. That's just a very simplistic way of explaining it, but that's important because if, for example, something changes, they need to move the machine and they ask you to adjust the stealth, that's what they mean. Pointing these black sensors towards this star. Happened to me when I was a sub-eye. I had no idea what they were talking about. I was just fiddling around until something happened. There is actually also a laser that you can use. This little handle right here has a piece that if you press, a laser will pop out, and you can use that to guide it directly onto the quote-unquote star here. Something as simple as that. So this is our stealth machine, and we use this at Jackson and at UMH for the cranial intraoperative cases. Electrocautery, there's a Bovie, there's a bipolar. Bipolar bi, too. Bovie, named after William Bovie, University of Michigan. That is why that's a yellow and that's a blue, because he was from Michigan. But that's William Bovie was one of the grad students under Harvey Cushing. The Bovie is actually a neurosurgical tool for electrocautery, fun fact. The bipolar, Leonard Mallis in the 60s, similarly, neurosurgical tool, but they're essentially, their jobs, burn tissue so it stops bleeding. Simple as that. And these are what there's a passing the Bovie, the one with one prong, not Rainclips. Didn't know what these were. Now I do. Essentially, the scalp is very vascular. When you cut through it, you want to coagulate some of those blood vessels through the Bovie, but you don't want to burn everything, particularly with these longer incisions. What you can use is these Rainclips. So some attendings prefer them, some don't. But what they'll do is they'll basically go onto the edge of the skin flap and pinch the skin at that area. So it basically mechanically stops the blood flow, kind of tourniquets it off. And you basically line them throughout the entirety of the incision. Fish hook retractors, pretty self-explanatory, but if someone says pass me the fish hook, this is what they're referring to. These literal fish hooks that attach to muscle, skin, and then move things out of the way.
Hey Sumit, one funny thing with the Rainclips I remember is holding them for the first time, figuring out how they open and close. So not intuitive.
Not intuitive at all. Like, in fact, to open it, you have to close the clamp. You can kind of see here that if you were to close the clamp, it would open the jaws. And to close the Rainclip, you have to open the clamp. So it's a skill. You know, if you're ever like manipulating a Rainclip, just try one, just to see how it works in your hand. These are the kind of, when you're in the OR with one of the residents, like, no, you know, these are the kind of times to really, and Rainclips, they're like a dime a dozen. So if you drop one, no, there's never enough Rainclips in the field anyways. So we'll always just open more. Just don't drop it somewhere where like it's in the patient. That'd be problematic. But next. Drills. Neurosurgeons love their drills. There's different types. The two that I want to highlight here, the perforator drill and the craniotome, or the foot plate. So if someone says passing the foot plate or the perforator, a lot of the times when medical students put burr holes in, they're going to use a perforator. And the reason that is because the actual perforator will go through the hard outer cortex. It'll puncture through the cancellous bone and embed itself into the inner table. And once it feels, you can see there's kind of a lip here. Once it feels that the pressure on the drill as you're pressing forward gives, as in you've gone through the bone, the drill will stop. So there's a lower likelihood. It sometimes happens, the drill doesn't engage properly, but what happens is as you like punch through that bone, the drill will stop. The perforator, it perforates the bone. The craniotome drill has this part here that will slip under the dura. The foot plate will slip under the bone, but above the dura, such that when you're drilling, you're cutting. This is how you turn the cranium. This is how you create a bone flap. You want to be on top of the dura, but cutting through the bone. So this is, I didn't draw this. I found this online, but the point is made. Penfield dissectors, Roten dissectors, these are all just the different tools for microsurgical manipulation of tumors, aneurysms, those kind of things. So when someone says, pass me a Penfield 1, 2, 3, 4, 5, there's 5 Penfields. So essentially having just even a sense of which Penfield is what makes it so much easier. If someone says, pass me a Penfield, and the scrub tech is off, helping with something else, you can easily just jump in. And that's another way to get a good sense of how these tools work and what each attending would want at what time. Again, there's a lot of neurosurgical tools. This is just mainly to give you some of the most commonly used names. For spine, the different rongeurs, a kerrison, basically you would fit a piece of bone or tissue underneath or on top of this foot plate here, but underneath this biting part of the actual rongeur, and it would bite down so you can pull that tissue off. It doesn't cut below this, but it cuts right on top of it. So you would use that for inner disc spaces. You can use that for even sort of like bones when you're trying to cut through some of the cranial tissues as well, cranial bone. Pituitary rongeurs is basically just a big clamp, a big sharp clamp that allows you to remove disc from from spine procedures. It allows you to use the long kind of neck to get into places where you may not be able to fit other instruments. Flexile rongeurs, this one's what you'd use to bite off spinous processes. They come in different sizes, so you can use it to really chew away bone that shouldn't be there that you need to remove. So this was, for example, the only reason I brought this up was because we're going to be saying, Kerrison 3, curved, pituitary. Give me the Lexel. These are just terms and phrases you're going to be hearing a lot in the OR. At least you have a good sense of what each of these things are, so that you understand how they work. And if someone asks you to get one of them, or hey, pick up the Kerrison and bite this off, you know what that means. There's thousands of neurosurgical tools, but these are some of the ones that when I, at least as an intern, these are the ones that are commonly the things that are placed in my hands. I don't know if they should be, but they are.
So just general pearls. I think there's a question being asked right now, actually, which kind of it's a combination on this one. What specific skills and general pearls to be around and stuff. So prepared, respectable, active, safe. We've all mentioned those. More specifically, are there any specific pearls? How to suture, how to close, how to set up Mayfields. By all means, I think having all those skills are definitely something people would be like, oh yeah, he or she knows how to do it. But you have to also remember, as much as it is about showing your skills on particular sub-Is, it's also about showing how well you are at learning and working with people and being taught. I think one of the greatest traits specifically to sub-Is is how teachable you are. People don't really mind if you know how to clip an aneurysm from day one versus not. But what people mind is how teachable are you? And so you don't necessarily have to have all the skills and all the techniques down pat. And by all means, as an intern right now, I don't have these skills down pat at all, but I'm still learning. And I think being teachable is very important. I think that would be a general pearl as well, to be honest, because how teachable you are is what people remember. The more teachable you are, the easier you are to get along with, the more people will remember you. I think that's also a good point to have. And ultimately, guys, it's a 7-year residency. If it was something that you could learn and be ready for in 4 weeks of a sub-I, it wouldn't be what it is. So it's a big journey, but definitely suturing, helping close, helping show that you're willing to help, examine the patient. A good neurologic exam is always important as well, because don't forget, on sub-Is, it's not just the operating rooms, but sometimes being able to see consults as well. Very important. One thing we haven't really spoken about, but I think, something for you guys to keep in mind is also imaging, interpreting imaging. I think we kind of forget, we're all obsessed with, tying knots and all that, but you have to also be able to, read imaging to plan a surgery. CT scans, MRIs of the brain, specific sequences, what you're looking for, basic anatomy. When it comes to what other sort of basic knowledge you should know, I think that's definitely also the case, to know exactly where is the ventricle, what is this ventricle, what is that view, what are these views, what are we looking for in this spine thing. I think those are also other good pearls, other good skills to have as well.
No, I definitely agree. And be prepared, respectful, active, and safe. I think ultimately you want to be in a position where you are actively involved in progressing the case. That is either, or at least not doing anything to slow the case down. So to, Frank, to answer your question as well, the advice on specific skills, you're going to learn how to suture. You're going to learn. In fact, your suturing as a sub-I, towards your maybe your third away or your second away, your suturing ability is going to be better than that new interns, guaranteed, for sure. Balancing the scope, setting up a Mayfield, these are kind of things that help the case go on faster. So if the scope is already balanced and you walk in, and these are the things, right? What does balancing a scope mean? this talk is really tricky to do when we want to teach you how to do those things, because you need to physically be by a microscope and learn how to balance the scope. It is just two buttons, but where those two buttons are, it takes a lifetime to figure out if you don't know. Unless you're reading the manual. Which is why hopefully when COVID kind of settles down, we can go into more of these like live discussions. We can go to UMH. When I was a medical student, one of the he graduated last year, one of the chiefs taught us how to do some of these things. What our intrapupillary distance was, like, these are kind of things that he taught as well in a live setting. That's something that we were hoping that we would eventually be able to get to, and ideally that'll be in the next few months. We can do that, and we can talk to Dr. Komatar as well about getting that set up. But these are the things, as long as what you're doing helps progress the case faster, you're active, you're doing something to move the case forward, that's someone who's productive in the OR. Megan, to answer your question, if you're an MS1 or 2, would you recommend asking to scrub in for a case, or should you wait and do so if asked by a resident attending? When I was a third-year medical student, I scrubbed in on a case with one of the attendings, or rather, I was in the room, and I did the latter of those. I waited. And so I remember, I'm sure Victor's heard this story a lot. I waited. I was told in this attending, you have to be very respectful, deferent, don't speak unless spoken to, that kind of stuff. So I stood, everything was moving very quickly in the OR. I stood by the side. He walked by me once. Didn't want to bother him. He was definitely, he's moving something around, getting something ready. Walked by me again, didn't want to bother. He was moving back and forth very quickly. The third time he walked by, he stopped, looked at me and said, I'll never forget, neurosurgery is not a spectator sport. And then he said, by the time I was your age, I had closed my 100th craniotomy. However, not to say that you need to have closed your 100th craniotomy. What I'm saying is that you need to be active in these situations. Ask the attending, hi, pleasure to meet you, sir. Pleasure to meet you, ma'am. I'm one of the medical students. I would love to be, I'm interested in neurosurgery. I'm interested in scrubbing in. Would it be acceptable that I do that? And then you ask one of the residents, hey, can I scrub in with you? And we will help facilitate your gloves. We can help facilitate getting you scrubbed into the case. You can scrub in with us and next to us, but these are the kind of things that you want to be active. You don't want to ever be in a position where you're just sedentary in an OR, because then you're taking up space. You don't want to do that. You want to be active. You want to be like, because that's how we give you more opportunities to learn. You want to scrub in and close, the squeaky wheel will get the grease. So I would always recommend know how to scrub in, and then ask if you can scrub in. If it's the first time you're ever scrubbing in, then I would ask one of the residents after the case or before the case to show you how to do it. But to the attending, you should know how to scrub in. Victor, what do you think?
Yeah, I agree. One way to really show interest is to scrub in and be there. But also, I don't know if this might be controversial, but scrubbing in and being there is one thing, but utilizing your time wisely in terms of being productive and developing as someone with an interest in neurosurgery may or may not be best spent standing at the edge of a spine case, not being able to see the incision. I think there is value to scrubbing in situations where you're not actively involved. But I also think, time is precious. Once you become an intern, you realize that even more. And understanding when's a good time and when's not a good time or a useful time is something that I don't think you can answer straight away, but just keeping your wits about you as to how much you actually learn doing things and in what time and what value you hope to return from. Because in one way, in Sumit's story, neurosurgery is not a spectator sport, but at the same time, he could have easily said, well, why are you scrubbing in when I don't even know what your skills are like? We haven't met before. It's if you can't see the spine, then are you really getting anything out of it? And is the attending even noticing? If that's what you're trying to do. So I think it's always good to definitely try to scrub in and see cases, but make it relevant to where you are with things. Watching an aneurysm clipping may be cool the first time, but the second, third time may not be so useful if you're a medical student, and getting to that stage of clipping is still years ahead of you versus perhaps reading more about the aneurysms themselves. Anyway, that's just my 2 cents to keep it a little bit different. Do you want to go to the next slide, Sumit?
Yeah, sure. The next one was just the open forum one.
Oh,
And
and
then
this just reminds me as well. Our program director, Dr. Komatar, has informed me that Miami is taking a sub-Is this year for neurosurgery. So I'm not sure the exact dates to apply and everything, but I know our plan currently, with everything the way it is to accept visiting students from other institutions. So by all means, consider Miami. Reach out to us. Reach out to our office. To see, because it's one thing to talk about all of this, but it's another thing to be able to show you guys exactly what we know and what we do every day.
I think Eric had a question. I'm currently an undergrad and applying to medical school. What are things to look for in a medical school specifically for someone who wants to pursue neurosurgery? That's a great question. I think what you should look for is an institution that has an in-house neurosurgery program, because you're going to need, this is way down the line, but you're going to want to be in an institution that has a neurosurgery elective. You can take it home because you're going to need those letters. You want a place where you have a lot of research opportunities in neurosurgery. Neurosurgical research is getting more and more competitive to get, but also good applicants are having greater and greater neurosurgical publications. One of the very first talks that Victor, Damien, and I did was about this exact topic, about neurosurgery research, the application process, and everything. And I think if you're an undergrad and you have a good interest in neurosurgery, then for sure pursue it. Pursue it in such a way where you have an active plan as to determining what type of applicant you want to be. In the sense of what research interests you have. If it's general neurosurgery, branch out and try to get projects in your name, to the mouths as many of the attendings and residents as possible, as someone who is fundamentally reliable. If they're given a data set, that data set should be done as soon as possible, so that they give you and trust you with greater and greater responsibility. But I think the most important, particularly at your stage now, is finding a medical school that has a neurosurgery program attached to it. Not to say that if you go to one that doesn't, you'll never become a neurosurgeon, but it's just easier that way, because that way you can meet the residents, you can form good relationships with them. And then, you get good research opportunities, and then you get to go to the OR without having to go to an entirely separate institution or entirely different campus. Like the Jackson's right across from Miller's medical school. So if any Miller student wants to go shadow, they literally walk like 15, like not even like 30 seconds. They're in the neurosurgery ORs. And then this is something where, look to the classmates above you that have gone through this process, and that way, you get a good sense, and reach out to, you can reach out to Victor, you can reach out to me, you can reach out to Damien and any of the other residents. If we have any other, any other pearls or wisdoms, but that's what I would do if I was in your case, and go to a place that has a lot of non-neurosurgical options as well, because you want to make sure that this is exactly what you want to do. This 7 years is long, super, super rewarding, but it's long. So if you are interested in something more or as the same as neurosurgery, then I would very highly consider, the option that maybe neurosurgery is something you don't want to do. Damien, Victor, and I, like, neurosurgery was it. Like I actively tried to find something that I loved more than neurosurgery, and I couldn't. So that's why where I am here. Plus Victor as a co-resident is like the greatest person, so you couldn't leave him alone.
Yeah. Despite the joys sometimes of this job, it's great, and finally when you're in the operating rooms, it's a different feeling. You kind of realize, I've been in the operating rooms last couple of days already, and it's I can tell you now, when I walk into a room, I feel a lot more comfortable than I did day one. So that's only in the span of 8 months. So the learning curve is exponential, really is.
So and then I think Iggy, one of the questions was, where can we find the recordings of these Zoom sessions? Is there a central repository that maybe we can send out as well, or?
Yes, it's in the neurosurgery page from YouTube. I sent the link earlier so that link, if you click on it, that's the main page for neurosurgery in YouTube.
Perfect. Thank you, Iggy. And I re-put that link just now as well into that question about where the Zoom recordings are. And on that link as well are other Zoom recordings, not just the resident hour ones, Dr. Morcos, Dr. Komatar, Dr. Ivan, any of the big neurosurgeons in Miami, any one of them, all the pediatric ones as well. You know, all of the surgeons that do these Zoom sessions, we all place them on that central repository. So if you have any specific interest at all, those are the places to go. And then, you know, again, if there are any more questions at all, please feel free to ask now, or you can by voice or even just by typing in. But you know, the next neurosurgery residency hour, the resident hour, will be how to apply for neurosurgical grants as a medical student and as a resident. This would be more so geared towards students who are interested in neurosurgical research and how to fund some of that research, particularly in academics. The ability to get funding is a pretty pivotal part of becoming an academic neurosurgeon or being an academic neurosurgeon. So that starts even as medical students. You don't have to have a PhD or anything. I received a few neurosurgical related grants as a medical student. So just having the opportunity to know where they are, what they are, and how to get them, that's kind of the topic for the next talk. So just as like a little plug for that one, it's going to be on a month from now. And here's all our information. So Ingrid Menendez, she's the administrative director of our program. So any questions you have specifically about different Zoom sessions, if you want to get involved in the department somehow, you know, you can talk to Ingrid and she can forward information to one of the residents, or you know, if you have any questions regarding any of the Zoom symposiums, for sure, go ahead and reach out to her. Dr. Komatar, our fearless leader, who basically made this possible. If you have any questions about shadowing or any questions specifically, he can refer to one of the residents. Then Damien, Victor, and I are our contact information. Follow us on Twitter, follow us on Instagram, and yeah, if there's any questions at all, feel free to ask.
All right, guys. Thanks for your time.